Okay. Well,
All right.
sorry about the delay, everybody. Firstly, I want to thank everybody for joining this webinar this evening. Firstly, let me say, without sounding flippant, that there is a solution to COVID. Without sounding flippant, it is Mashiach, Messiah, a promise of the prophets. And when Mashiach comes, there'll be no more sickness, no more suffering, no more war. It'll be good for all 9 billion people on this planet, all children of God. But if he does delay a little bit more, we have to know what to expect. There is nobody better to speak on the subject than Dr. Ryan Noach, and there's nobody better to interview than Elana, Afrika. So I want to thank you both for doing this. And I just want to point out that on our last webinar on the subject, we had over 70,000 views. So you guys are doing something right. So I want to thank you both for doing it. And Elana, over to you.
Thank you so much, Rabbi. And Dr. Ryan, it's great seeing you again. I know that you don't want to be referred to as a doctor, but I think in this time, what I've experienced today alone was the following. I had someone call me in a panic. I had someone call me, say, I'm not a journalist, but I have all these questions. And he eventually popped me an email. The function that I ran away from just now before I joined here, when I let them know that this is what we're talking about, it was like saying to someone, this is the last function that we'll ever have. And we were only 20 people wearing masks. And so there's this unnatural almost panic if this is your only world that you are infusing yourself in. And I think Rabbi set the tone very well when he said that this is probably not a way to panic. This is probably a way for us to find solutions. But I don't want to get holy on you tonight. I want to just get to the facts. A while back, we started this conversation, and I don't want to say you warned us, but we did talk about a fourth wave at the time. Take us back to that conversation and then explain what a fourth wave means now in relation to what we spoke about then.
Evening, Elana, and it's great to be with everyone again. An important webinar, considering last time, I think it was, just amazing that it got so many views. Elana, I've done some preparatory work and prepared some slides. I'd suggest you let me run through those. I'm going to answer that question on the fourth wave and a bit more, and then we can take some Q&A. And I know you encourage the Q&A, so people can use the Q&A tool and chat to you that way. So I'm going to go ahead and share the screen, and you should just tell me when you can see it clearly.
Okay, we can see it. Thanks so much. Here we go.
Okay, so we're going to quickly run through an overview of where we are in the pandemic, progress on vaccination, some work that we've done on vaccine safety and effectiveness, and there's no more important message than that one, and the longer term impact of COVID. And just as we start on the pandemic progression, just to say that I've had to spend today reorganizing the presentation. It is a somber message today, and today is actually an important day in the history of the 2 years of the COVID pandemic that we've been living through, with the identification of a new variant in South Africa. So I want to start off by sharing some information about that. Comes at a time that I think everybody is planning their holidays. Schools are finishing next week. A lot of people are taking early leave, exhausted after a tough year, and it's come at an inconvenient time from the perspective of the epidemiology, the mobility that people experience at this time, the fact that small coastal towns fill up but don't have the healthcare resources to deal with a high burden of disease in those areas. And so to be frank, it is a little bit worrying at this time. So let me tell you about this variant. It's being referred to as B1.1.529. This variant is just identified now. The news released this morning by our very advanced genetic surveillance teams, led by Prof. Tulio de Oliveira at KZN University, but also elsewhere in the country. And we are now seeing that this variant is responsible for about 90% of the recent spike of infections that we're seeing in Gauteng. Now, why is that relevant? Well, the relevance of that is that, as I'll show you on the next chart, it's quickly displacing the Delta variant, which was the predominant variant, and becoming the predominant variant. And as a result, it's very likely that this contributes to another wave. What's a bit concerning about this variant is that it has over 30 mutations indicated on this chart that you see here. going to change my pointer so that you can see it, but all these little markings that you see here are locations where there are mutations in the SARS-CoV-2 virus, and there are more than 30 mutations in this variant. Of particular concern, 9 of the mutations are on the spike protein itself. And you may wonder, why is that a concern? Well, the vaccine antibodies are predominantly working, and the antibodies that we develop after an infection with COVID-19 work predominantly against the spike protein of the SARS-CoV-2 virus. And because there are these mutations in the spike protein, the virologists who I've consulted with today predict that this will really lead to reduced antibody susceptibility. What does that mean in simple terms? It means this is likely to be a highly contagious virus, likely to spread very quickly. Whether it will be quicker than Delta, quicker than Beta, nobody at this stage knows. But the likelihood on a kind of a desktop review of this mutation is that it's going to spread very quickly. I think the good news in there that we're looking for is that the T-cell immunity, which is the cellular component of our immunity, we have an antibody component and a cellular component. The cellular component is largely preserved based on the view of the mutations around the S protein, which is a different part of the virus as opposed to this, so this is good and bad news. And the feeling from the virologists, and at this stage, I must emphasize that it's only a predictive feeling. There is not evidence to support it yet. It will probably be highly contagious, but perhaps not more virulent. In other words, the severity of disease may not be worse. That's the good news. We really can only tell about the virulence of the disease from the real world experience. And, we need to, unfortunately, wait and see what happens as there are infections that spread. On the left-hand side of this chart, you can see an indication of what's happened with the predominant variant, right? In green on the left, you see the Beta variant. And along came Delta in red, and you can see how quickly the Delta variant displaced Beta and became the predominant variant. Now look what's happened on the extreme right-hand side in blue. I hope you can see it on your projected version. But you can see the sudden uplift of blue in 1 week. That is B1.1.529, the new variant that has not yet been named by the World Health Organization. I believe they're planning to name it tomorrow. Does seem inevitable to me, and I'm not a virologist or epidemiologist, but based on my understanding and the conversations I've had, it does seem inevitable that this will drive a variant-based fourth wave, with likely quite a steep trajectory based on the contagious nature of this. And so why this webinar comes at an important time is because I can warn you to take every necessary precaution. There is a new hazard and a new risk. And I would urge everybody to take those precautions. The advice to give now is to vaccinate and to avoid public gatherings and indoor spaces as much as possible. So just pivoting to looking at the period that we're dealing with, I must say it's truly been a tragic period. At Discovery, we've lost 24 family members, 24 of our employees. We've lost 14,319 customers to Discovery Health. And as a country, we've just faced an unprecedented tragedy of about 270,000 excess natural deaths during this period. That's affected family units, children, workplaces all over the place. And by this stage, many of the people listening will have been personally affected in some way. It's truly tragic. This gives you a view of what we've seen at Discovery Health. We've tracked and traced things very closely. We have almost a unique data set because we have wellness data, health data, some activity data, physical activity, credit card activity and the like, and we can actually link all of these things together. So this unique data set gives us globally unique insights. You can see that across Discovery Health, just picking out a few issues, there have been 440,000 positive cases. Of those, 12,300 have tested positive more than once, and a proportion have tested positive more than twice. So unfortunately, you can catch it more than once, without a doubt. We've had 60,000 of those people who have been infected admitted to hospital. That proportion remains stable now at about 13.5% to 14%. It's pretty stable there. So of all the people that get infected, that's who lands up in hospital. And of those in hospital, about 10% land up being readmitted to hospital. Very sadly, the case fatality rate, the proportion of deaths with the denominator being total positive reported cases, is 3.3%. Of course, the fatality rate of the disease is much lower because many cases don't test positive and go asymptomatic and unnoticed, about 80% probably of cases. From a vaccination point of view, delighted to tell you that across all adults administered by Discovery Health, 61% are now vaccinated. And as I'll show you on a later chart, across people over the age of 60, 80% are now vaccinated, close to 80%. And this is really important. Just quickly, not spending time on this chart, just to remind you how we think about the prediction of a wave. And your first question was, how do we think about the prediction of the fourth wave? Well, we think about it in terms of what is the immunity that the population has, how much behavioral change and physical contact is there that leads to spread, and what is the resilience of the population, what is their ability to resist infection or resist admission to hospital. And we think about it in those terms. That hasn't changed. From an immunity point of view, probably the single most important issue now is vaccination rates, and also the underlying number of people in the population that have been infected. We had a very extensive third wave, and we think that a very high proportion of the population has been infected, up to 80%, probably been infected. The problem with this is that this new variant may not be responsive to those antibodies. And in addition, as you've seen from our data, reinfections occur. So just to remind you of the theory, how we think about a wave. It amazes me, Elana, that there are still conspiracy theorists out there, and I come across them in my role pretty often, who tell me that, COVID is just the flu. And I hasten to point out that really the data supports that it isn't, and so does the anecdote. What this diagram shows you is it uses the Medical Research Council of South Africa's excess natural death data. They've been tracking excess natural deaths for about 17 or 18 years. It's now very predictable how many deaths there'll be in the country from natural causes every year. We have had 270,000 extra deaths over and above what's predicted in this period since March last year. And we can reliably assume that probably 90% or more of those are COVID related. You can see the three waves depicted across the bottom, just so that you had a graphic to time the three waves. In the yellow chart, the yellow bubble, it shows you as a factor of the baseline of the expected deaths, how many deaths have occurred. So in the first wave, we had 1.5 times the expected deaths. Between the first and second, it dropped to 1.1. The second wave, we had almost double the number of expected deaths in that period. And the third wave, 1.6 times the number of expected deaths. It really is, unequivocal that COVID is causing tragic death to the extent that the death rate has almost doubled at some points and doesn't return to normal between the waves. I hope that if there are any conspiracy theorists on this webinar, this data is just, there is no sophistication in the data. It's just the number of people dying in the country. When we look at the three waves, we compare Discovery Health's data and our analysis around this. We see quite an interesting pattern in wave 3, which was the Delta wave. So wave 1 was Alpha, wave 2 was a Beta wave, wave 3 was the Delta wave. You can see that if you look at the infections, the shape of the curve looks different. Firstly, wave 3 peaked higher, and secondly, it lasted longer. In short, there were many more infections in wave 3 than in the other two waves. That resulted in more admissions. They peaked at the same level as wave 2, but it's a broader curve, and it resulted in more deaths. Again, you can see it peaked where wave 2 peaked, but broader, longer, and more deaths. The admissions and the deaths in wave 3 were not as severe as in the previous wave, but it was the volume of infections, the number of infections in wave 3 that caused the tragedy that we saw in that wave because of this highly contagious Delta wave. So if you had a choice of a highly contagious virus or a very virulent virus that causes severe morbidity, the virologists and epidemiologists have told me you would choose the one that is less contagious. It results in less deaths, even though it has severe consequence as a result of just spreading less readily. The worst combination, of course, is one that's both contagious and highly virulent, and that is the most severe. So when you compare the admission rates, this chart compares admission rates to hospital. Look just at the light blue ones, which is the risk-adjusted admission rate, adjusted for age and chronic disease. And when you adjust the admission rates for age and chronic disease, you can see that the third wave actually had the lowest admission rate of the 3 waves so far. 12.6% of people that tested positive landed up in hospital. 2 reasons for that. The one is that we've learned to treat the disease quite effectively and we manage it better now out of hospital. So we required less admissions. And the general practitioners in our town are doing an unbelievably brilliant job of managing out of hospital COVID. They are the experts. This disease is largely managed out of hospital. And then the second reason is also that the virulence of the Delta virus seemed slightly lower than that of the Beta virus. You know this, but I just wanted to share with you our updated data to say who gets sick. It's very clear that the elderly and those living with more chronic diseases are at greater risk of falling severely ill. You can see that in this column for people between the ages of 60 to 70, about 30% of them require admission to hospital, 70 to 80, 45%. And people living with chronic disease, those with 3 or more chronic diseases, have more than a 32% chance of being admitted to hospital. And these 2 independent variables can be overlaid to create quite a dangerous combination of age and chronicity. I don't want that data to be misleading. I talk to young people and they say to me, I'm not elderly, I've got no chronic illness, I'm not at risk. I don't need the vaccine, I'm not at risk. Well, let me tell you that 60%, 58.7% of people admitted to hospital in the Discovery Health experience during the 3 waves are between the ages of 18 and 49. Now, clearly, the mathematically minded amongst the audience will say, well, there's many more of them. That population is much greater. And so per capita, the admission rate is lower. Completely true. The admission rate is lower for those age groups, as I showed you on the previous charts. But don't think that because you're young and fit and don't have chronic disease, you're immune. You're not. We have 18 to 49-year-olds being admitted, and I'll show you on an upcoming chart, the very next one, how a 40-year-old vaccinated person has died in the last 2 weeks. So this is very important. And if there are take-home messages, this is one of them, Elana. Do not think you're immune if you're between 18 and 49 at all. So starting on the left-hand side of this complicated chart, and it's complex, I apologize for that, but it's important. I wanted to just, in an infographic, demonstrate to you that the people in hospital are made up of a mixed population of the unvaccinated and the vaccinated, and you can see them as red and blue dots. Keep in mind that in the Discovery Health population, there are far more vaccinated people than unvaccinated, especially in hospital, because they tend to be elderly. We have 80% of people over the age of 60 vaccinated of our members. And as a result, when you're looking at a sample of who's in hospital, you must remember that the vaccinated pool of people is much larger than the unvaccinated. That said, what these infographics on the right show you, categorized per age group, is they show you in the blue luminous color, the dark blue filled in color, the proportion of vaccinated people in different states of COVID-19. Firstly, admissions. Secondly, ICU admissions. Thirdly, on ventilators. And lastly, unfortunately, having passed away. This is just data for the last 2 weeks. What you can see is that in the last 2 weeks, we've only had 1 death of a vaccinated person. It says 100% because there was only 1 person in that age group that died. 40 to 49-year-old vaccinated person died of COVID-19. But the rest of it, if you look right across the board, you can see that vaccinated people tend not to die in all age groups. Vaccinated people tend not to land up on a ventilator. And vaccinated people have a much lower chance of being in ICU, keeping in mind that there's a much larger vaccinated population. The one other thing to say about this chart is that the vaccine does not give absolute protection. And as I'll show you in our data just now, it confers excellent risk mitigation, but not absolute. And that is very important to keep in mind. We need all of the precautions, even if we're vaccinated. I think what's quite welcoming is that if you look at that Medical Research Council data in the last month to month and a half, what you see here in the white portion of this block here, you see the proportion of people who are dying, unfortunately, sadly, who are over 60 years of age. And look what's happening to that over 60-year-old group. You can see a steady decline in the proportion of deaths from the over 60-year-old group. And the reason is because vaccination has reached quite highly penetrating levels now in the over 60-year-olds. So this is starting to show us that the vaccines are working, and we're seeing it now coming through in that excess natural death data. So this, Elana and ladies and gentlemen, is our prediction for the fourth wave. You can see the prediction in the blue line over there. Have a look at that blue line. We are predicting, and COVID is hard to predict, so we may get this wrong. But at this stage, we are predicting a lower, flatter wave with less severe morbidity associated with it. We think vaccines play a big part in that, and we think that people that had previous infections during the third wave, which was a severe wave, has played a big part in that. Importantly, our analytics have concluded that we would have had 55,000 more deaths in South Africa by now in the absence of vaccines. Let me say that again, 55,000 more individuals would have died in the absence of vaccines. And that's simply take the curves from prior to vaccination and continue those curves and those mortality rates. That's what we believe would have happened. And so, you know, we think vaccines do protect us from some deaths in this fourth wave, but not all the deaths. We are unfortunately at the start of the fourth wave, in our opinion and in my opinion. What this chart shows you is the reproduction factors, which is the number of people an index case spreads the virus to. So if I have it and I spread it to 2 people, the reproduction factor is 2. So it's a measure of how quickly this is spreading through the population. Anything above 1 means the virus is spreading exponentially. It's an exponential curve. At 1, the spread is linear. So unfortunately, 6 of the 9 provinces are currently with a reproduction factor above 1. Only the Eastern Cape, KwaZulu-Natal, and the Free State have a reproduction factor at the moment below 1. Gauteng's reproduction factor on the 23rd of November, a few days ago, 2.47. This is rapid exponential spread. And today we think we understand why. Probably because of this highly contagious variant that has been identified. So that reproduction factor is worrying. If you look at just the case count, and I'm sorry that some of this may appear small, but if you look at the case count, if you look carefully at Gauteng's case count, can you see that little red spike? The other place you can see a small red spike, you may not see it on your version of the broadcast, is in the Northern Cape, but we are seeing the beginnings of a small red spike from this long, nice flat period that we've lived through. It looks like Gauteng is the province to watch. Daily infections are beginning to rise there. And the problem with that, in my view, is that the timing is terrible. Schools breaking up, people taking early holidays from work, the school rage in Plet and in Belito next week. And I think what happens, potentially one scenario, is people jump onto airplanes and in their cars, they travel around the country, they take the virus with them from Gauteng, and we'll end up with a concomitant national wave with seeded virus in all the coastal areas where people are planning to travel to. So the mobility of this period, I think, is problematic. The National Institute of Communicable Diseases does COVID-19 virus or SARS-CoV-2 viral scanning of sewage water. This is a very good lead indicator. In other words, it tells us ahead of time if there is virus that's being shed from people's bodies. And guess what? We saw 2 weeks ago in the week 45 report from the NICD, from the National Institute of Communicable Diseases. So that's the week of 8th of November. We saw a spike in various sub-districts through Gauteng that you can see here. And the main spikes were in Tshwane. And it turns out that in our data, what we are seeing is the main Gauteng infections at the moment are in people between the ages of 20 and 29 in Tshwane Central, in the center of Pretoria. It seems like there's an outbreak at Tuks. And as those people are going home or, moving around Gauteng, that seems to have been where this outbreak has started in our data. And this is just, our view of the data that we see. The other bit of concerning news is that concomitant with this, we've seen over the last month, and I bet you people on this call will vouch that they've experienced this. We've seen a spike in non-COVID-19 infections, particularly influenza A, that blue line that you see spiking over there, and this rhinovirus and enterovirus, which has been catching kids, giving them diarrhea and bronchitis and severe nasal congestion, and they've all been giving it to their parents. And in my family, we've been victim to that too. So we've had this outbreak now running for about a month. It has resulted in some non-COVID-19 related pneumonia admissions to hospital. Most of the people get better, but the interesting thing about this viral syndrome, and this is mostly anecdotal now, it's not in the data, is that people seem to take 3 to 4 weeks to get fully over it. And this leads to compromised immunity if people are living with other viral infections. So we seem to have a convergence of these two situations happening. Why are people getting flu, influenza A and enterovirus and rhinovirus? Why has that happened? Well, the short answer is people have resumed their normal behavioral activities. I think you can see it and feel it. There's traffic out there. Our offices are getting fuller. People are having parties and year-end functions. We can all see it. Well, our data supports that. Let me share some interesting data with you. From Discovery Insure's mileage driven by Discovery Insure clients, you can see this clear drop in mileage driven during the lockdown, a steady increase. There was another lockdown during wave 2, steady increase. There was another lockdown during wave 3, and have a look where we are now. We are almost at the same number of kilometers driven as pre-COVID now in October 21. So on Discovery Insure's data, mobility has resumed. If you look at Google's mobility data, which they publish for public consumption, you can see that they track the reasons for mobility, and almost all of their reasons for mobility are up, except for residential activity, which has flattened a bit, and I think we all understand why. But everything else, grocery shopping, retail and recreation, visiting of parks, visiting of transport services, it's all up. So that's why people are getting flu and why they're passing diarrhea to each other, because of school activity and all of these activities. In fact, when we look across the universe of Discovery, we can see this behavior resuming. In the bank, credit card spend is back to pre-COVID levels on everything except for travel. Online purchases have become in-store purchases with one exception. People who swap to online grocery shopping seem to have changed their habits, and there's a lot of online grocery shopping still going on. But the rest of spend is back to in-store. Vitality flight bookings, this is interesting. During May to October last year, there were 41 flights booked, virtually none. During May to October this year, we have had 360,000 flights booked. So travel is back. Exercise is 2.56 times what it was last year. I'm sure you're getting tired of this. Smoothies are more than 2 times the number of being consumed than they were this time last year. Healthy dining, people eating out and eating healthy meals, almost 2 times more than it was last year. So our data shows that there is a change in behavior, and this poses a risk to us ahead of this 4th wave, as we've seen in Europe. So let me talk a little bit about Europe because there are lessons to be learned. Just 2 quick slides on Europe. The first is this data out of the UK. And on the left-hand side, it shows the number of cases per 100,000 people in the population. In the middle, ICU admissions, and on the right, deaths. And what we're seeing in Europe is unfortunately a return to lockdowns as these infections have surged. Austria did something unprecedented and started a lockdown a few days ago for the unvaccinated only. They've locked down the unvaccinated in Austria, and they've now made it mandatory to have everybody vaccinated, all adult citizens, from the 1st of February in Austria. And we are hearing noises of similar moves elsewhere across Europe. So we are seeing this European wave. What's pretty interesting about the European wave, and I find this chart absolutely astounding, on the left-hand side, you can see the proportion of the population vaccinated in descending order. On the right-hand side, you can see the number of deaths for those countries, and they're the inverse of one another. So if you look at the top of the graph, Ireland and Portugal, you know, per million people in the population, low deaths relative to the rest of Europe. If you look at the bottom of the chart, Romania and Bulgaria, where there's a lot of vaccine hesitancy, very high deaths per million population relative to the rest of Europe. So vaccination delinks the infections from the deaths. That's what it does. The infections still break through at a lower rate, definitely 50 to 70% lower infections, but it delinks the mortality from the infections, and that's what we need in our country. So let me talk about vaccination progress then, considering that important European data. And I'm going to pick up the speed a bit here, because I think I've covered the real meat of what you wanted to hear. We're going slower than we should. We have administered about 25 million doses. And if you look at this middle chart, that's the important one. People over the age of 60 across the country, about 64% vaccinated. The 50 to 59 is about 58% vaccinated, and the 35 plus group about 45% vaccinated. So declining by age. We need to get that up, Elana. That's the bottom line. We've got sufficient stock in the country to vaccinate 80% of the population. We slowed down some of the orders, some of the deliveries. We did not cancel any orders at all. So that stock is there and available for South Africa. Close to 70 million doses have been procured for South Africa. That's there. We've slowed down the deliveries because we've got 16 million doses in cold storage in South Africa, and demand has dissipated. And so it makes sense to slow down the deliveries for now. What you can see on the daily vaccination rate in this chart is that the daily vaccination rate, 7-day moving average, the average over a 7-day period, has dropped by 55% from mid-August, when it was at its peak, to now in November. So we've had a drastic decline in demand. I go to the office every day. I'm in one Discovery Place. I look at the queues in the vaccine center, and it's visible. Don't need this data to tell you. So the centers are empty. The president set a target of 70% of the country's adults vaccinated by year end. It was the right target to set, but unfortunately, our prediction is that we're going to get to about 50% by year end. You can see those predictions here on the right-hand side. I'm going to move quickly and talk about what's happening with our employees. Very interesting experience with our own employees. We were the first JSE listed company and one of the first large companies to introduce mandatory vaccination for our employees. This chart was from the 19th of November. And today being the 25th of November, I'm delighted to tell you we're at 94% vaccinated across our workforce. Mandates work, and they're important, and you know, they're legal and they're legally sound. And we are just totally thrilled that we can hopefully protect our workforce against what we may be facing should there be another wave now. There's meant to be a little video that shows you the progression of this, but it's not playing, so I'm going to move on. Oh, there we go. So this is the progression since we introduced it. And you can see how quickly it's climbed over a period from the beginning of October to now where we are, the middle of November. So it's really been a very successful program. There are going to be 1 million questions from the people attending about boosters. Everybody's asking, when can I get my booster? Well, firstly, the data out of the UK from England is showing that the boosters don't only top up the immunity, in other words, don't restore it to where it was because of the waning, they actually boost the immunity and elevate protection well above the previous peak. So if you look at the Pfizer curve here, you can see that from 5 weeks after the second dose, there does seem to be a waning in the UK data, the British data of immunity. It's slow and steady. It's not a rapid waning. But what happens when they get boosted is that the immunity is taken to a level above where it was after the second dose. So it is additive to an extent. And when you look at the relative risk of a symptomatic infection, what is the risk of a person who's fully vaccinated and has had a booster relative to an unvaccinated person? It drops the risk by more than 80% after that third booster dose. So on this British data, it looks very clear that boosters are important. You can look at other data, which is also equally relevant and astounding. If you look at the October wave in Britain versus the November wave in Britain, you see a stark difference in the age groups. It's easy to see. Look at the age groups 80 plus. In the November wave, you can see that there is a decline in the case rate, the number of new cases diagnosed per capita on a daily basis. That case rate is declining. What's the difference between October and November? Same country, same population, same age group. What's the difference? They gave the boosters in November and there was 80% take up by people over the age of 60 in the UK. And so you can see what's happened there. That tells the story. You can also look at Belgium versus Netherlands. Quite interesting. Belgium introduced boosters. Netherlands didn't boost the elderly. Belgium had a new wave and so did Netherlands. But the people who were boosted in Belgium, you can see that their daily cases leveled off, whereas the people that were not boosted in the Netherlands, their cases haven't leveled off. So on this empiric data, it seems very clear that boosters are appropriate and they work, and there is a waning of vaccine efficacy. I've kind of covered it, so I'm going to move on just to say that it continues to be a controversial topic in the South African context. So let me tell you where we are with boosters in our country. That is the big question people are asking. Firstly, for those people who participated in the Sisonke trial, they were healthcare workers and people involved in the healthcare industry. There were 480,000 of them. The second J&J shot is now available. It is actually an extended regimen. It's not truly a booster. It's an extended primary regimen, and it's been available since the 9th of November, and people have been receiving those doses. The booster for the people who have received the double shot of Pfizer is imminent for those in the immunocompromised population groups. Again, it's probably more of an extended primary regime. It's not truly a booster. It's because the immunocompromised people don't have the same immune response to the double shot. So give them a third shot as part of the primary regime and make sure their immune systems are well primed. We heard from the Department of Health that this is imminent, should be by or no later than the 30th of November. They've defined who the immunocompromised groups are: people living with cancer, people living with renal failure, people on drugs that impair the immune system. And there's going to be a requirement to have a letter of motivation from your doctor to say that you're living with one of those conditions, and then you'll be eligible for the booster. We have approached the Department of Health to ask that medical schemes who have this data and know exactly who these members are be allowed to give those letters to those members directly. And we're waiting for the go-ahead from the Department of Health for that. I'm optimistic that we'll get that. When do people over 60 get the booster routinely? Well, there is sufficient stock for this. So tick that box. There's not a supply problem. And with demand having tailed off, even less so of a supply concern. We are going through a process of awaiting approval from the South African Health Products Regulatory Authority, the medicine regulator, because Pfizer has applied to them for permission to administer boosters in the country. So that review is ongoing. My own view is it will be imminently approved based on the data I've showed you and more data, much more meaningful data that SAP is reviewing. The third part is that there are some political considerations. the World Health Organization has taken a very dim view of rich countries giving boosters when poor countries haven't managed to issue the first round of vaccines. And with our president being the chair of the African Union, our country being miles ahead of any other country in Africa at the moment from a vaccination perspective, I think there are big political issues at play. My prayer is that these don't get in the way of the boosters. And then the 5 to 11-year-old vaccinations are also important, a slightly lower dose. I think those will come last out of all of these things, but it is something we need to stay focused on as well. I hope some of you saw our research that was published in the media and published on our Discovery Health Insights Hub. Brilliant work by a large team of actuaries and clinicians in my team who have done astounding analysis of vaccine safety and efficacy. And there could be no more important time than now for me to just summarize those findings for you very quickly and give you peace of mind around vaccines from what we've seen. We studied a period from the 17th of May to the middle of September. We looked at 1.7 million unique data points for 1.2 million vaccinated adult members. So this is people like you and me, Elana, adults, probably many people on this call, living in South Africa, receiving the vaccines from our cold chain. So it's very relevant to all of us, and it's at scale. This is statistically relevant population level work. It's one of the largest vaccine studies of its kind in the world. And it covers many admissions, deaths, infections. And as I said up front, we have this unique data which allows us to look at the end-to-end experience. The short summary of the results is that you have a 79% lower chance of being infected if you're vaccinated with the double Pfizer shot, a 92% lower chance of being admitted to hospital, and a 94% lower chance of dying. It's that simple. I can spend lots of time, and the actuaries can spend even more time with people who want to interrogate the data. We're happy to do so, and we are doing so. But the headline is this: reduce your infection risk by 79%, your admission risk by 92%, and your death risk by 94% by taking the double shot of Pfizer. What we see is that it really becomes most effective after the second shot. So the days after the second shot are indicated in the green bars. The days after the first shot are indicated in the blue bars. And you can see that spike in effectiveness after the second dose. And it really becomes most effective at day 14 after the second dose. We saw over the 3 months after the second dose, no waning in effectiveness. We only looked at a 3-month period after the second dose. Why? Because our vaccination program only started on the 17th of May, and to get this data, we didn't have more time than that. We will report again in January, February for the 6-month period. But for the 3-month period, we saw no waning in effectiveness at all. Whichever way we looked at it, by gender, male or female, by the type of chronic condition, or by the province that you're living in, the vaccines remain equally effective. So whichever subpopulation you're talking about, they are equally effective. The one thing that we did notice is that people over the age of 80 have 7% less efficacy than people between the ages of 30 to 39. And I think that's well understood, and that's the reason for boosters for the elderly. The same is true for people living with multiple chronic diseases. They're still at higher risk. People who've been vaccinated do unfortunately die. It's rare. Your chances are significantly lower, but it doesn't make you bulletproof. So please still be careful. Very importantly, people who've had a prior COVID-19 infection have the unique opportunity of creating what's called in the scientific community hybrid immunity, but what's being referred to colloquially as super immunity. It's a superpower. So give a vaccine to somebody who's had COVID-19, a double dose of the Pfizer shot, and they have a 98% chance of a lower chance of admission to hospital than an unvaccinated individual. So this is dramatically important. So whether you've had COVID-19 or not, have the double shot. What's pretty interesting in this analysis is people really want to understand what's the risk of socializing with unvaccinated people. Well, in red is the indicative risk of infection between 2 unvaccinated people in a closed, poorly ventilated space, right? And so the size of the bar gives you a graphical indication of the risk. Relative to that, if one of the 2 people is vaccinated, you have a 10 times lower risk of the vaccinated person being infected and a 20 times lower risk of them infecting you. And if you're both vaccinated, a 200 times lower risk of being infected for both parties. So when people say to us, why have we mandated vaccination in our offices? It's because we want our offices to be a safe space. It's because we're not prepared to lose another life if it's in our hands. We've lost 24 employees, and we are absolutely determined to create a safe working space for our employees. And our evidence demonstrates that that is one way to confer some safety, some level of safety. Many people have reached out to me during pregnancy to say, what do I do? I'm worried about damaging the fetus, about interfering with the pregnancy. Well, there are risks of vaccination in pregnancy, without a doubt. The vaccine does have side effects, and there are risks in pregnancy, but the risks of not vaccinating are greater, as this data shows you. What it shows here is that your risk of a preterm birth, if you're unvaccinated and you catch COVID-19, is much higher than your risk of a preterm birth if you're vaccinated and you catch COVID-19. So dramatic difference in the risk of preterm birth, and also in giving birth to a low birth weight baby. And obviously we use the birth weight of the baby often as a proxy for its health and its gestational development. So it's unequivocal and globally recommended by leading regulators and scientists and doctors that, you know, in pregnancy you should be vaccinated. What's important is that mortality risk is in our hands. We can manage the mortality risk. There's 2 things we can do. We can be physically engaged and keep our body mass index low. And in Vitality, we refer to that as highly engaged Vitality members. What the orange chart here shows you is the mortality rate of highly engaged Vitality members. Think of highly engaged as exercising 3 to 4 times a week and normal body mass index. Whereas poorly engaged Vitality members in blue have a much higher mortality rate. And the same is true in vaccination. You can see the vaccine group versus the non-vaccinated group. So it's in our hands to control this. Let me say that complications in our data post-vaccination are extremely rare. I must qualify that. Mild complications occur relatively often. 10 to 15% of people get a headache or a fever or a feeling of malaise, flu-like feeling. It lasts a day to 48 hours and it's gone. That's relatively common. I'm talking about complications that have any kind of medium-term implication. They are rare. They are far outweighed by the risk of COVID-19. But the 3 that stuck out in our data is the 3 most common ones are swollen lymph nodes called lymphadenopathy, inflamed muscles, which causes pain in your muscles and discomfort called myositis, and a tingling sensation in the fingers and the toes, typically called paresthesia. It's an inflammatory condition of the nerves. And these do occur as complications of vaccination. The vaccines do have side effects. The same 3 things occur in COVID-19 with much more regularity. And you can see the COVID-19 bars in gray and the vaccine side effect charts in blue and yellow. But they do occur. Just to make it clearly visible for you, the big lines are where these complications occur as a result of COVID-19. And on that relative chart is how often they occur as a result of vaccination. And you can see it's very infrequent. So the vaccines are safe and they work. So moving swiftly to the last part of the presentation, and I'll be quick here. You know, what next? You know, where we going? Well, I'm hoping that 2022 will be a period of pandemic recovery. We're hoping it will be a period of booster vaccinations. It'll likely be a period of endemic infection where COVID-19 is there to stay. It's endemic. We live with it. People get it from time to time, but we're well protected. And I think we will be living with the consequences of long COVID, and that will become the focus of the COVID debates. We're quite worried about that, and I have a chart coming up about that. There are long-term consequences to the behavioral disruptions we've been through. Mental health is the biggest, but there are others, and I wanted to share some of that with you because it's very important, and there's a message for the people that are listening. So during this period, what we've seen is a real impact to normal healthcare utilization patterns. Of course, there have been COVID-19 related admissions to hospital, but the rest of in-hospital care is really reduced dramatically. The blue line shows you how it's dropped below the baseline, the dotted red line of pre-COVID levels. And what we've seen out of hospital, and it remains well below today as we talk to you now, and out of hospital, we've seen the same. A marked reduction and behavior change where people's health-seeking behavior has changed. Whichever part of hospital care you look at, all the procedures are down. Cardiacs, gastro, tonsillectomy, spinal procedures, all of it's down. When you look out of hospital, what's quite interesting is pathology claims are dramatically up. I think there's lots of COVID testing on the go, right? So we understand that. But there is a move to care out of hospital, a move away from large hospitals to care at home. Problematically, though, we see a massive decline in preventative and screening care. And I'm going to show you in a moment that we're already seeing the early implications of that. Long COVID is real. It's manifesting in our data. We're seeing a 2.5 times increased risk of diagnosing diabetes and a 1.5 times increased risk of diagnosing a cardiac condition post an acute COVID infection. And our data is unequivocally showing in our claims data that people are living with ongoing consequences of COVID-19 after an infection. Looks like something like 1 in 7 to 1 in 10 people. So it's a high proportion of people. And it seems that those that have poor health status beforehand are at greater risk of developing these long COVID symptoms. From a screening perspective, you can see our vitality health checks are dramatically down. What's worrying is that the number of mammograms that we've done, 17% down, and the number of pap smears that we've done, 18% down. Now, guess what happens if you don't screen properly for cancer? Well, you need not be a scientist to answer that question. The answer is that people present with more advanced cancer. So let me show you our data here. This is the first audience to see this data, and it is troubling indeed. The top of the chart in dark blue, you can see people who are diagnosed with cancer and the proportion who are in stage 3 or 4 or an advanced stage of the disease. It's been relatively stable over 2018, 2019 and prior. Have a look at 2021. That is a massive jump. There is 2% more people being diagnosed in stage 3 and 4. There is a jump of about 1 to 2% in stage 2, and there's a reduction of about 3 to 4% in stage 1. In simple terms, getting away from the fancy terminology, we are seeing unequivocal data in our experience, which is showing that people are presenting with more advanced cancers. And it's simply because the screening from 2020 and 2021 didn't happen. And so it wasn't picked up early. This is a direct impact on the severity of the illness, the treatment plans, the toxicity of the drugs, and the mortality. And of course, from a health insurance and an actuarial perspective, also the cost of care. It has an impact on all of that. We are seeing evidence of growing mental health issues. I'm not going to spend too much time on it because I'm already over my allocated time, but to say that it seems worse in the, interestingly, 25 to 29-year-old group in terms of the percentage jump. And it's interesting that the Z generation people are struggling to deal with the lack of connectedness, the lack of social connectedness and engagement. And there's research emerging from across the world now that shows that that Z generation needs interconnectedness to define meaning. And that's manifesting in our data in a spike in psychosocial claims in that younger age group. We're also seeing a spike in psychosocial claims greater in females than in males. And my own views and some data from our UK business shows that it's probably because working at home for women is genuinely harder than working at home for men. This is not a gender biased view. It's just simply that women do tend to be the organizers of the home and the organizers of children. It's a very important role they have in the home. Put them at home now and prevent them from going to the office and force them to stay at home, and the stress levels are inordinate. They got to deal with so much more. In our UK business, it's particularly visible because in the UK, there is not much domestic help available. And so when moms have to work at home and the creches are closed, they're looking after their kids and working simultaneously. And so in our UK team's data, this is exaggerated and really visible. Home workers are definitely working harder and are definitely more productive, and that's been good for business. I would warn that this may be a productivity honeymoon, because I do think there is a risk of burnout, and we're seeing some of that in the claims data that we're seeing. We've seen a 500% increase, 5 times the number of people registering on our mental health program in October 21 than we saw in June 2020, 5 times the number. And although there's this increase, we're seeing the care being delivered out of hospital, which we favor. We think it's better. But both psychiatrists and psychologists are choosing to deliver the care out of hospital. These are the insights I was referring to from our British business, Vitality Health in the United Kingdom, where they did a survey of large employers. And they showed that 45% more time is being spent at the workstation by home workers. 70% of remote workers are experiencing aches and pains. In medicine, we call that psychosomatic features of mental disease, where your body starts manifesting your bad mental state. You start having aches and pains everywhere, and it's a somatic manifestation of your psychological deterioration. 13% are self-medicating and 25% have reduced their daily physical activity. This is a British sample and a British cohort, but I think it's a global phenomenon. This is I'm now at the very end, Elana, so just indulge me. I'm over my time just to finish up. The course of COVID-19 could be changed by the advent of these 2 very relevant new antiviral drugs. There's one from Merck and one from Pfizer. The Merck drug shows a 50% reduction in risk of hospitalization or death when administered out of hospital within 3 to 5 days after diagnosis or after infection with COVID-19 to the people who are at severe risk, to the highest risk group. So there are conditions, right? The highest risk group must get it within 3 to 5 days of the diagnosis, usually get it out of hospital, and it leads to a 50% reduction in severe disease. A similar story for Paxlovid, which is the Pfizer drug, but with a higher effectiveness on their empiric data of 89%. These are both awaiting approval from the FDA in the US. In the United Kingdom, they've already approved molnupiravir from Merck. What's interesting about the Pfizer drug is that it's a protease inhibitor, which is a drug that's well known to us. We've been prescribing viral protease inhibitors, antivirals, for a long time as doctors. So it's a well-known drug and actually probably pretty cheap and readily available. And so that's pretty good news. So please be assured that at Discovery Health, we are in discussions with both Pfizer and Merck at the highest top levels to try and access this drug for our country and for our members as quickly as we possibly can, through all the appropriate regulatory means. Let me end by a call to action and a plea to each and every person on this webinar. Vaccinate, but in addition to vaccinating, employ the Swiss cheese model method of mitigation of disease, which means multiple layers of cheese. If you imagine that Emmentaler cheese with the big holes in it, put multiple layers of cheese between you and the virus. Social distance, wear a mask, stay outdoors, stay in well-ventilated areas, and vaccinate. And if you take that Swiss cheese mitigation model approach to mitigating disease, you are better off. I would say be festive. My advice is be festive. I may be criticized for writing that here, but But I believe we need some festivity. We're dealing with a scourge of mental health disease. It's been a tough 2 years. There are silver linings. We'll get through this. I would be festive, but act responsibly in so doing, and avoid huge public gatherings, especially indoors. Please support our local economy. Our restaurants, particularly those with outdoor seating, our delivery vendors, our hospitality venues, our economy needs your support, but do so responsibly, taking into account the first two pieces. Be aware, be compassionate, and provide good support to those around you from a mental health perspective. Let your radar be switched on to pick up early warning signs. There is a second pandemic coming of mental health disease. And then I have a particular view about a need to support the elderly. The loneliness and the anxiety associated with COVID-19 for the elderly is not to be underestimated. The social distancing, the isolation, and the fear that I'm most prone to infection has had a massive impact on the elderly in general. And I would ask that you please support the elderly amongst you with sincere compassion. So that's my story, and I'm going to stop my share and hand over to you. And I'm sorry that I exceeded my time, but I thought the messages were important.
Brian, the messages are important. I mean, when we started speaking at the beginning of the year, we talked about the second wave, the third wave. The fourth wave at that stage was going to be a mental health wave. And this morning it changed. I have such empathy because your research is accurate, and I'm excited about the fact that it wasn't just medically based. I mean, you talked about the elderly and you talked about how we need to support local. You gave us precaution and even layers of what one can do, which is some of the questions as to what one can do. But a part of me thinks, what a tough gig, because we were going to talk about only the fourth wave, and this morning the news broke, for those of you that have joined in later, about the new variant. And like you say, you had to adapt your presentation. You also mentioned that this virus is unpredictable, and the only way that we can help ourselves is we can't think that we are immune. What is interesting about your research, which I noticed, is that the group of people that think that we are immune and that is most reluctant to vaccinate is also the ones that are suffering the worst in the mental health environment. Like mentally, we are fatigued and our bandwidth is depleted. And so I want to thank you for this thorough explanation. I want to get to some of the questions. So we're going to quick fire it because we have been busy for an hour. And thank you so much for joining us. I see that some of you are still on. There's a few questions that's coming through that's asking for practical advice, and I'm going to get to them. I'm 74 years old, says Anonymous. I'm a member of Discovery Health with diabetes as well as hypertension. My second Pfizer vaccination was almost 6 months ago. Am I now eligible for a booster, especially in view of the fourth wave and the new variant?
That's the burning question. So the mass vaccination program in South Africa is a government-led program, and the boosters or any doses of vaccine can only be given to those who are eligible according to the government's rules. As I described in detail in the presentation, the evidence is leaning strongly towards advocating boosters. 6 months is probably maybe a little bit early. The data from the UK shows that the waning tends to be around the 8-month mark. The booster seems highly beneficial and is unequivocally safe. And so I would say we should be giving boosters. Somebody with your risks and at your age should definitely be one of the first to have a booster, in my view. But we do need the country to legalize that and provide the supply to do so. The steps, as I said in the presentation, I'm repeating them because perhaps some people missed it. There was a fire hydrant of information. It is with the South African Health Products Regulatory Authority now, which is the medicine regulator. They are reviewing Pfizer's application to administer boosters in South Africa. Once they legalize it, the Department of Health, guided by the Ministerial Advisory Committee for Vaccines, will then go through a process of determining who's eligible, what's appropriate, and it's ultimately decided by an interministerial committee. I should say that those teams have functioned very responsibly and coherently to date. and I have confidence that they'll make the right decisions. I hope that they do it timeously. I would like to start giving boosters by early next year if we could.
Just another quick fire question and a suggestion, and I think it's a great one. It says, is COVID out of hospital only handled with medication, masking, social distancing, washing of hands, sanitizing, staying at home, and correct lifestyle? What about healthy eating patterns, correcting our nutritional supplements, and also implementing fasting? Doctors don't discuss this. Why, says Anonymous.
Yeah. Look, I mean, there's a lot of controversy around diets, and you know, it just depends who you speak to. I mean, I think what's really exciting from our point of view is that our highly engaged Vitality members definitely have better outcomes from COVID-19 across all ages. In fact, a diamond status member who's 60, I'm now quoting the data from memory, which is always dangerous, but a diamond status member at the age of 60 has the risk of an average 40-year-old by virtue of that status. Now, what does highly engaged, what does diamond status mean? It means that they're physically active, they have got a well-controlled body mass index. In other words, they're not overweight or obese. And in almost all of those cases, they participate in our healthy food program and are eating healthily as well. So a healthy lifestyle mitigates severe COVID-19 risk. There's no doubt about it. So prescribe exercise and healthy food as a doctor without a doubt. Which diet should it be? Is there an anti-inflammatory diet? I'm really not the expert on that. I consult with an expert dietitian once a year. I would suggest do the same. It's a good thing to do for your health.
There's quite a few questions that's coming through. Remember the slide that you showed of how many people ended up in hospital, and then the vaccinated person who then died of COVID. So there's about 3 questions that asks, did the 49-year-old have any comorbidities? And I want to also just say this, I think doctor brought a lot of reassurance. If you've missed out on anything, this will be live on the Chabad Facebook page, and we will make it accessible to all of you so that you can go through the stats and the data step by step. And there was so much reassurance in there that showed us what to do and how we can prevent ourselves from getting ill, right? But the question is asked, did the 49-year-old have any comorbidities?
Yes. Yeah.
Is that the answer? Oh,
that's
yes.
the answer. The answer
okay.
is the person between the ages of 40 and 49 who died fully vaccinated.
Right.
The only death in that age group over the last 2 weeks of our members, that person unfortunately did have comorbidities. Okay.
I just want to check with you, 4th wave and our behaviors, is it directly linked to the new variant?
I don't know the answer to that. It's a hard question to answer. Is the variant a contributor to it? I think yesterday we would have said we don't think there's a variant yet. Today we're saying it's almost certainly the major contributor to it. But there's no doubt that the mobility data and the behavioral change that I showed you, where people are a bit COVID fatigued and lockdown fatigued and are all back to what they were doing pre-COVID, that's a contributor too. So it's multifactorial, but it does look very much like this variant is highly contagious and is going to drive the 4th wave, yes.
Your slides that showed how there's a decrease in vaccines being administered. We had a question that asks, are there risks of vaccines expiring and being unused?
At the moment, there's no risk of expiry, but that's the reason why the delivery dates were pushed out on the other vaccines, because we have 16 million doses as a country in cold storage. It would be a crime to allow them to expire. And so the Department of Health's team, led by Dr. Nicholas Crisp, who have done an outstanding job here. We deal with them almost daily, and they've really done a brilliant job in securing vaccines for our country and rolling out a mass program together with the private sector. You know, they are being prudent and watching those expiry dates carefully.
We had another question, and there's a few that relates to it. Why are people not asked to be vaccinated? And this says specifically in hospitals. Also, I think this connects to your we think we are immune statistic that you brought to us.
Yeah, I think what the question is asking is, why aren't there more mandates for vaccination? Why,
Yes.
The mandate is, I can tell you as a company that's advanced this, it's undoubtedly the right thing to do, but it's a difficult thing to do. For us, it was counterculture. We are not a company that says thou shall to our employees ever. We're a company that enjoys debate, vigorous debate, diverse views, and then ultimately we reach consensus. In this case, though, it's a matter of saving lives and creating a safe environment. So we think that mandates are going to become commonplace. And certainly we're seeing many large listed companies now, many large employers insisting on vaccination. Your question there was related to hospitals. Kudos to the Mediclinic group and the Life Healthcare group. Those two groups have announced mandatory vaccination for all their nurses. And I tell you, for me, if I'm in hospital, I want a healthcare team treating me that's fully vaccinated for me as a patient. In fact, if I'm working in a team as part of a healthcare team, I want that team to be fully vaccinated. And for many of the doctors who work in the hospitals, they want to be surrounded by fully vaccinated staff. So I think these mandates will become commonplace. What you do see in Europe is the Austrian scenario. It's very interesting what's happened in Austria. Austria is made up of 9 states or 9 provinces or jurisdictions, whatever you call them. But it's got a kind of a split government with a socialist party and a conservative party. 2 of the states are socialist, 7 of the states are conservative, making up 9 states. The conservative states have much lower vaccination rates and much worse COVID-19 outbreaks at the moment. The socialist states have much higher vaccination levels, much more controlled outbreaks. Their vaccination level is 65%, or it could be 67% for the country. But that 33% unvaccinated, concentrated in those 7 areas, is really driving the infection rate. And so what the government has done is a lockdown of the unvaccinated. It's quite something. They've said to the unvaccinated, you shall not leave home for 10 days, starting on the 22nd of November. And then introduced a mandate for every citizen from the 1st of February. I think we're going to see big parts of the world go this way.
I can't help but look away from the fact that we started with this first wave. We had many chats about this. Then there was lockdown, which brought along, I think, its own challenges of not just businesses being depleted, most of us losing our confidence, also lockdown, a second, a third wave. Then remember, there was all of our conversations around our teenagers being vaccinated. That caused major concern. That almost feels like it was so long ago, because since then there's a 4th wave and now also a new variant. I can't help but look past the question that we had earlier, and we've got 2 of them asking about vaccinations for 5 to 12-year-olds. And you earlier mentioned in lower doses. So, I mean, I want to make light of this, even though it's such a serious topic, but it almost feels like it's becoming more and more ridiculous. Now a new variant, and when you showed me the protein count, I almost fell on my back, because I was like, what is this? I mean, what are we actually fighting? So, Doctor, are we going to win this?
Absolutely. I have every confidence we're going to win this. I'm extremely optimistic, in fact, notwithstanding today's concerning news about the variant. We believe that the 4th wave will be of lesser severity than the previous waves. And, the really informed scientists and virologists continually remind me of the following. The viruses mutate to become more contagious and cause less severe illness. And the reason they do that is because they want to survive. The best way for a virus to survive is to be able to move quickly between a host. So, highly contagious, but not to paralyze that host. They want the host to remain mobile and remain functional so that they can get that host to transfer into other hosts. So a virus over time, its mutations tend to become less virulent. The influenza pandemic of 1918 lasted 3 years. They had, 3 years of that pandemic. They had, I think, 4 waves, if I remember correctly, from the influenza pandemic, and then it settled and it became endemic. Every year across the world, we lose 110,000 people to influenza. It's dreadful. It's a terrible disease, but we live with it and it's endemic. And the same is going to be true for COVID. We will get past this. It will become endemic. The epidemic phase will be past. Hopefully these antiviral agents mean we can protect people much better, and we will get back to normality. And I'm convinced of that. I just do want people to be cautious through this December. That's all. I want people to just think about their behavior through this period.
Ryan, I know we are out of time, but we have your time, and it's so hard because you're in a medical profession and you have a really important job, and we've got your time. There's so many questions coming through. I want to address this one, for instance. In your presentation, you spoke about the success of the Pfizer vaccine. Please, can you comment on the success of the J&J? Now, while you think about that, I want to quickly go on to the next part. I mean, you spoke about influenza. The latest thing that I see, because I've got littlies and teenagers, is foot and mouth disease that's coming our way. I also had to treat a fungi recently that was a form of ringworm that I'm going, is this part of COVID? Is this a joke? Mobility has increased. And so there's a lot of questions that comes through about boosters, which we've addressed, the variant, and whether the vaccine that we currently can get, whether the new variant will be able to, how would I put this as a non-medical person, be killed by the vaccine that we already have, and then also the effectiveness of the J&J.
Yeah, a lot of questions there. So let me try and go through them one at a time. The reason we reported on the Pfizer effectiveness and not the J&J effectiveness is because the South African Medical Research Council has convened the Sisonke trial, and they are running a formal trial around the J&J effectiveness. So, it was not our remit to interfere in that trial. We have supported them with our data. Our actuaries and clinicians are providing them access to our data on an anonymized, aggregated basis so that they can absolutely use this data. And we're working very closely with them. We jointly presented the first round of information. In fact, it was presented by the Minister of Health, the first round of evidence that showed at that point in time that the J&J first dose was highly effective in protecting health professionals. Anecdotally, we see in the hospital groups that much fewer of the medical fraternity are severely ill from COVID-19. And our data that we're looking at supports that the J&J vaccine is highly effective. The formal research is going to be published, I understand, imminently, early next year by the South African Medical Research Council, and we'll use our data and others' data as well to support it. So please don't be perturbed by the omission of J&J. This is more about what we're entitled to research and what we're not.
Right.
The second part of your question was...
excuse me, doctor. Sorry. Yes, please continue.
You should really call me Ryan, Elana. There's no
I know. But
yeah.
when I speak about all these medical things that a lot of people find scary, I just have to say, doctor, for the reassurance, doctor, please tell us.
The second part was, will the vaccines protect us against this? I asked the same questions of all the virologists today. The answers I'm given is that it's highly contagious and we're likely to see many breakthrough infections because of these mutations in the spike protein. However, the T-cell immunity, the cellular immunity, seems to be robust. And as a result, the vaccines are likely to give us excellent protection against severe disease. And that's the current view. I must qualify two things in our discussion because we've been quite informal. And so I must just set the record straight on two things. The first is we're not officially in a fourth wave yet. We speak of the fourth wave. We're not officially in a fourth wave. It is my view that we're seeing the start of the fourth wave and that this will be the fourth wave. But we shouldn't call it the fourth wave yet. It hasn't met the epidemiological definitions of a fourth wave. And the second part is that this variant is brand new. We're the first in the world to identify it. It's only been announced today, and there's insufficient study and research around it yet to know exactly how it's going to behave. So I just want to qualify our conversation with those two kind of disclaimers.
Ryan, there's so many questions that are coming through, people asking about medications, also whether one can do elective surgery without being vaccinated. There's a concern, Mom, I'm going to call you anonymous, that asks, can I send my child to camp?
Yeah. You know, the camp organizers will take the right advice to make sure whether it's safe or not. I'm very worried about depriving children of a normal childhood existence. I think it has severe ramifications that will probably outlast COVID. I think the social and the mental health impacts are severe. Children are not likely to get severely ill. They do on occasion, but it is very rare. They are not likely to get severely ill. The danger is really actually to the adults when they come home and they've been exposed. I guess if you put me on the spot, if it was my child, today I would probably still be sending them on camp. I would be definitely testing them rigorously when they returned before I exposed them to a lot of people. I would also want to understand the mitigation strategies that the camps are undertaking.
Ryan, it's an interesting time because it is a time where we are seeking joy and light and spiritual growth. And you put it beautifully in your last slide where you gave us the precautions, and I love the cheese analogy. I'm so using that on radio tomorrow. The cheese analogy of how, you know, the cheese with the holes.
Well,
and
that's a World Health Organization approach. So the Swiss cheese approach. So you shouldn't quote me. You should quote them.
I call it what you want. I'm using it tomorrow, but I love that analogy. But also the fact that you said, stay safe and be festive. Your presentation was factual and it was based on data, but it wasn't a negative report. It gave me hope because it gave me understanding. And so I want to leave our audience tonight with reassurance, because we're still going to wash our hands, sanitize, be socially distant, and be careful so that we can last for a very long time to make a lot of change in the world. And so while we are leading up to a very important time and a holiday time in all of our lives, seeking joy, what's your last message as a medical professional that we have access to firsthand that just gave us a lot of data and research?
Yeah, I mean, message number one is get a vaccine. If you're not vaccinated, go tomorrow and get vaccinated. I think message number two is be prudent. Just be smart. Avoid big public gatherings, specifically indoors. Wear your mask, even if it's bugging you and uncomfortable. There's evidence to show that it works. So, that is my call to action. The third is just be cognizant of the unintended impacts that this COVID is having. Look after the mental well-being of those around you. Take particular care for the elderly, and look after yourself. Introspect. I know my own body is giving me warning signs. My wife tells me I'm giving warning signs, and I can feel I need a break. I'm going to take a break. And I would advocate that for many. I speak I'm seeing evidence in our data, and anecdotally, I speak to too many people who are stressed and anxious at the moment.
Well, there you had it. And we want you to have a safe holiday and stay informed. In Afrikaans, we call it fopnies. So don't believe all those WhatsApps that are going around. Here's the facts, and you can see it on our website as well as on the Facebook page. This video will be available so that you have access to it and can go through the data and the research bit by bit in chewable chunks, because I think Dr. did a really great job in presenting it to all of us, because we are not in the fourth wave yet. I wish you a happy holidays. And may we always seek joy, even in these interesting times. Doctor, do you want to say anything else before we go?
Just to say thank you to you, Elana. You're really brilliant at this. And to Chabad and Rabbi Masinta, who really do so much good, are continually kind, make their time available for the good of people and create this platform. And I really do thank them for that.
Thank you for your time. Have a good night.